Good morning, judges. It is our honor to be here to present our work. We are Team 41 from National Taiwan University Hospital and Tsinghua University. Our project is to predict the AKI recovery with MIMIC-4. AKI is a common and vexing clinical challenges. For most patients, AKI resolves rapidly, but for up to one-third of the patients, AKI fails to resolve. This acute illness could be contributed by volume depletion, post-operation AKI, sepsis, or obstruction. And this persistent AKI may result in oliguria, congestive heart failure, pulmonary edema, metabolic acidosis, and encephalopathy, and even death. Let me introduce the definition of AKI. By definition, AKI refers to an increase in serum creatinine to 1.5 times baseline or more within the last 7 days, and is staged according to the critical staging based on the severity of creatinine value. While the recovery of AKI is defined by transient recovery of plasma creatinine level, which is less than 1.1 of baseline within 7 days of AKI. As we can see from our diagram on the right, highlighted in red box, irrespective to the patient's underlying condition of chronic kidney disease or a healthy person, persistent AKI has a significantly higher mortality rate than patients who had recovered. Hence, there is a need to predict if a patient is progressing towards a transient or permanent one. One of the ways is through biomarkers. Recent studies have found biomarkers urinary CCL14, plasma proenkephalin, plasma cystatin C, and urinary NGAL to be effective. As we can see that the AUC-ROC value was approximately 0.7 to 0.8, which is deemed to be clinically effective. However, is this clinically feasible? Currently, older biomarkers allowed in practice remain to be plasma creatinine. Other prediction model has also been proposed. This involved the age, gender, creatinine elevation, and urine output. The AUC prediction of 5-day recovery from AKI was 73.1%. Race and ethnicity also played an important factor. In the recent COVID pandemic, Black patients was found to have a higher risk of AKI than white patients. This factor required further validation. Given the discrepancy in the various prediction models, biomarkers, and factors, our project aimed to recruit ICU patients without dialysis suffered from AKI, and predict factors such as age, race, ethnicity, and Charlson Comorbidity Index that contribute to transient recovery based on plasma creatinine value.
For the dataset, we use the data from MIMIC-4 database. Here we only include ICU patient over 18 years old diagnosis with AKI within their first 7 days in ICU. Then our model will be their creatinine value after 7 days counting from the day where they are first diagnosed with AKI. 0 means not recover within 7 days and 1 means recover. Then for the feature included in the model training is shown on the slide. Then for the method, this is an imbalanced dataset with approximately 22% of not recovered subjects. So we use mode technique to deal with the data before training, and we also use median value to input all of the missing data. Then for the model, we try logistic regression as our baseline, random forest and XGBoost classifier as our model. Afterwards, we use set value and decision tree to better visualize the model outcome. Lastly, there are some bias in the model performance between different races, so we also address this problem and solve it using the PCA.
Here are the prediction results for our XGBoost, random forest, and baseline logistic regression model. From the RC curve on the left, we can see that the random forest classifier achieved an AUC of 0.74, and the XGBoost model having the best performance of 0.79 AUC, which is almost 20% higher than the logistic regression model. We also present other evaluation metrics of our XGBoost model on the right.
For the feature importance, the left one is the set value, so we can conclude from here that the lower the first day creatinine value is and the greater the base creatinine value, the higher the chance to recover. Next, this is the decision tree coming from the random forest.
We further compare XGBoost models' performance among different races. The AUC between different races varies from 60-ish to 90-ish. This bias of race will cause the model's fairness problem. In order to reduce the bias, we experimented using the unsupervised learning technique to process our input features before training the model. We used PCA to decrease our feature dimension to 20, then successfully observed that the largest AUC gap decreased and achieved a rather even performance between different races.
We conclude that machine learning model performs better compared to conventional models in predicting recovery of AKI after 7 days. Top features using machine learning model including first aid creatinine, tracking of baseline of each subject. Model fairness between different races can be achieved by applying PCA to the features before training XGBoost and our model. This is our team. Thank you for listening.